Good evening, everyone. My name is Dr. Sachin Gupta, and I'm Chief Operating Officer of Whitehall Hub and Physician VC Singapore. Today, we are going to have a very interesting panel where we are going to discuss about innovations in cardiology. Cardiology and cardiac care has been at the forefront of preventive healthcare for last, 2-3 decades. Today, we have some of the most known figures in field of cardiology will be discussing with us how innovations in cardiac care are shaping up, you know, the cardiac care. So we have Dr. Mrinal Kanti, who is senior cardiologist and former president of Cardiological Society of India. We have Professor Dr. Rabin Chakraborty, who is current president of Indian College of Cardiology and senior vice chairman of Medica Hospitals, Kolkata. Dr. Chakraborty also heads the healthcare committee for Bengal Chamber of Commerce. Then we have Dr. Samir Gupta from Delhi, who is group director of cath labs and cardiology at Metro Group of Hospitals. He also heads the healthcare committee for Punjab, Haryana, and Delhi Chamber of Commerce. So, welcome to the panel members. Uh, yeah. So now we'll straightway move into today's discussion, which is innovation in cardiology. So my first question is very generic in nature, and we have seen technology kind of changing the way care is being delivered, especially during COVID. Prior to COVID, there was very little penetration of telemedicine or very little acceptance of telemedicine. But then, with COVID came, we also saw a regulatory push from the government approving national telemedicine policy, and patients also started accepting that. So in a way, technology kind of enabled access of healthcare to a larger mass of people. Having said that, there are innovations which not only help in improving access. There, some of them they impact clinical outcomes also. So we'll start with the panel from Dr. Das, and from all three panelists, one by one, will like to understand what are some of the key innovations in cardiac field that have changed the landscape of cardiac care uh, over last 5-6 years, and what does the future look like, Dr. Das?
Thank you very much for giving me the opportunity in this forum as a panel discussant. In fact, this is a very, very inspiring subject to me and very close to my heart as well, the innovations in cardiology. In fact, uh, there have been different aspects via which the cardiological innovations have given or taken a shape. This could be in the form of virtual care, in the form of remote monitoring, and AI driven care. So these are some of the ways by which the technology has driven the care of the patients of cardiovascular diseases to a very, very significantly improvised level. Now, so for the virtual care is concerned, as Dr. Sachin was telling us, that the telemedicine has spreaded like anything, especially during the Corona era. Now, this telehealth technology actually enables both the caregiver and the caretaker at the same platform, wherever both of them are. In fact, if the internet facility could be sent to the remotest area, then possibly in the remotest area also the doctor or cardiologist or the healthcare provider can reach them virtually. Since there are certain kind of things like internet speed and fourth generation, fifth generation, sixth generation concepts are there. I'm not going into the detail of it, but definitely with the development of the fifth generation and sixth generation speed of or bandwidth of the this internet, you will be able to see me virtually and shaking a hand with you. That sort of technological advancement is already there, but it is just at the lab level. So the telemedicine will take another shape with that kind of thing in future. Second thing, what I was talking about is the remote monitoring. Now, this remote monitoring was already uh, being taken care of in various fields, especially in the field of electrophysiology, to which Dr. Rabin Chakraborty is very much associated. This remote monitoring is very much possible either in detection or even after the detection of any abnormalities there, correction of the abnormality via again the internet technology. Say, for example, the person has developed chest pain. Now, that chest pain could be due to many causes, but if it is due to, say, cardiac attack or like that, with the help of single lead ECG, the healthcare provider will be able to see if it is sent to his center or a place by the health taker. Same way, there are certain devices like called pacemakers, CRTs, and all this. Now they have got different parameters which can be at some point of time very dangerous, or at some point of time they may not be helpful. Now those points can be taken care of by the remote technology, and monitoring can be done, and actual advice or the appropriate advice can be given. So these are some of the areas which can be again extended to many other factors, not only electrophysiology or electrodiagnosis, but also in imaging, and also in other areas can be extended. And third point, I was talking about the AI-driven care. AI means artificial intelligence or augmented intelligence, which are taking much more important role in our day-to-day life. When we are driving, you can see that if there is a jam in certain areas, your system will tell that area is having jam. Traffic jam, so you can divert your car. So this is a AI driven technology used in the automobile industries. Same way, in our system also we can use AI in different aspects, especially in the diagnostics as well as in therapeutics. So for the therapeutics is concerned, I'll specifically mention about the AI-driven therapeutics or digital therapeutics, because this is again coming in a very big way. This technology can pick up certain activities of yours, like whether you have taken the medicine at the right time or not, whether you have taken the exercise rightly or not, whether you have forgotten some medicines or not. So those kind of information can be picked up if you are connected to the system, and if they are seen, then they can actually advise you accordingly. If you have taken more calories, they can advise instantaneously that you should reduce that amount of food, or that amount of calories of food, and you should take care of yourself. So these are the ways by which actually you can be given real help through the digital technology and artificial intelligence. Over to Sachin.
Okay, thank you so much, Dr. Das. So this info was very useful. So there are three ways in broadly whereby technology is affecting cardiac care. One is access through telemedicine or remote access. Second is wearable devices whereby the doctors are able to actually monitor patients' health and parameters remotely. And third is the way forward, which is AI, which will shape up cardiac care in coming days. So, Dr. Rabin Chakraborty, so what is your thought about this? How technology is impacting cardiac care? Yeah.
Thank you, Sachin. I think Dr. Das has covered the key areas initially. But what is important is in relation to COVID, because these innovations were there anyway, but the application of these innovations, as COVID actually helped us in application of these innovation in such crisis period of this planet. He talked. You also did mention about wearable devices, which we are quite familiar with that, and also artificial intelligence. So, what is important that even in the critical cardiology care, we have instances where even the physician sitting at home can actually monitor the progress of a critically ill cardiac patient uh, in the critical care unit through these various technologies. This is one. Secondly, one more important point, which is actually started before COVID, but again in COVID, it got the whole process has been sort of accelerated, is the use of robots, robot guided intervention, robot guided application, even the drug delivery by the robotic system. These are the things which are extremely helpful. Similarly, there is one more thing which I just came across recently. For example, a known patient of mine, who is very well known to our chairman, Dr. Roy, and he had he's very old gentleman, very famous man, a spiritual leader, and had a mitral regurgitation, required mitral clip, and difficult for him to come down to any particular place for to at least to go to USA, and he wanted the best person to do it for him. So what has been done actually? This gentleman was in India, and the person who does transesophageal echocardiography, he actually flew from Mayo Clinic, and the doctor in India was also there, but there's another doctor in United States. He was also involved. So all these four actually work together as a team, and with something called proxy device. I'm sure Samir may be aware of this kind of proxy application of proxy system in such remote control mechanism by which you can do cardiac intervention. Because this particular doctor was unable to come to India because of COVID. And as we know, there is a travel ban for people to go to the United States, as well as this to and fro movement was not so comfortable. So this is one such application which I witnessed myself and found to be extremely helpful. And this application has been accelerated in results of COVID. So this is one such use. And therefore, it is very important for us to understand that although COVID has taught us a lot, but at the same time, it is very important for us to understand that with such kind of advancement of technology, both in healthcare, especially in cardiology care, we must continue to engage ourselves with such advancement and development, and ensure that the healthcare can be actually given to people at very remote areas. Dr. Das is heavily involved in healthcare of a rural community, especially in Sundarban and other areas. During this recent, there's a storm and there's a kind of a natural disaster recently, where Dr. Das himself was involved. I'm sure that during this COVID time, there are mechanisms by which those people were also helped. So there are various ways, especially the underprivileged community, the women and children were helped profoundly by application of various advancement of healthcare technology, including artificial intelligence, including other things. Coming back to arrhythmia, as we know, that single lead ECG is really very, very helpful because we can actually understand. We don't need to do all 12 lead these days. We can actually do sometimes 3 lead only and actually can capture the 12 lead, sometimes even 14, 16 leads sort of pictures by application of artificial intelligence. This is one such area which is extremely helpful. And these images can also be transmitted remotely by your artificial intelligence. So clearly, there are so many areas, but in India, I'm very proud that there are certain places in India are involved in advancing this technology further. But we have to ensure that we have to strengthen the marketing, strengthen the awareness, so that the application of this technology amongst Indian population, it's a huge country, huge population, and not only India, even the neighboring countries like Bangladesh, Sri Lanka, Nepal, other countries can, even Myanmar can also be help with this kind of advancement. That would be sort of my initial thought, and probably as we move further, we can talk more and more. Thank you, Sachin. Over to Dr. Sachin Gupta.
Thank you, Professor Chakraborty. This was very insightful, especially the remote robotics example which you gave. So that's very enlightening. So that is the way forward. So thank you, Dr. Sameer. So what is your thought, and what do you like to share with the audience today regarding technological advancement and how it is shaping up the cardiac care as well as the overall healthcare ecosystem? Yeah.
Yeah, thank you so much, Dr. Sachin, for inviting me on this forum. And I think the speakers before me, Dr. Das and Dr. Chakraborty, have very eloquently kind of summarized, what the healthcare system in cardiology looks like. But I'm going to give kind of a different viewpoint that perhaps no field in medicine has had more innovation in the last 65 years than cardiology. Major scientific insights such as cardiovascular pathology coupled with pharmacologic and technological advances have yielded breakthrough after breakthrough. And this is, one of the clearest examples is the longevity of people. If you go back and see the two biggest advances that have led to improved lifespan of people, one is antibiotics and the other is cardiovascular advancements of aspirin, streptokinase, angioplasty, statins. So these are all kinds of, cardiology has always been at the forefront for improving longevity. But despite these advances, the full potential of cardiovascular sciences and medicine, I feel, has not been realized. And the population health is suboptimal, especially in a country like India. Cardiovascular disease remains the leading cause of morbidity and mortality in India and also worldwide. So the question comes up that, how can we reconcile the seeming paradox of major advances in cardiology with the suboptimal kind of quality of care, some inconsistent health outcomes, and some unsustainable costs? I think the clearest explanation is that the healthcare delivery system is not sufficiently evolved to keep up with the advances in cardiovascular science and medicine. Indeed, the basic mode of healthcare delivery is inside the walls of the hospital and clinics, and this has been fairly static over decades. But the delivery system, I feel, is an impediment to the innovation transformation. And I think COVID has really changed that. I remember seeing one poll on one of the social media platforms which said, "What is responsible for the technological innovation in your hospital or in your organization?" And there were four choices. One was your CTO, your chief technology officer. One was, the fund manager. The third was the management, and the fourth was COVID. And everybody had chosen COVID because COVID really, really accelerated the adoption of technology. I think overnight, if 6 months, if 2 years ago you would have told me that let's have a meeting on Skype or on Zoom or any of these platforms, I would have said no. Let's meet in person. What is Zoom? But now we are also comfortably sitting and talking and having a discussion. So, Dr. Chakraborty and Dr. Das are sitting in Calcutta, you are sitting in Gurgaon, and I'm sitting in Delhi, and we're all here having a viable discussion, and our people are sitting there, our audience is sitting all over the world. And that's just phenomenal as to how all of a sudden we've adopted this technology. But, with COVID, not only have we adopted technology, we've also adopted the way things are done. Now, Dr. Das and Dr. Chakraborty very nicely talked about remote monitoring, wearable devices, the use of AI. But, in COVID times, especially, one very important thing that's happening is the way we do clinical trials. Clinical trials in cardiology or in any medical science are the backbone of our treatment. Whenever any treatment came out for COVID, whether it was steroids, whether it was hydroxychloroquine, the first thing was, is it backed up by a randomized trial? Are we sure this works? The remdesivir, does it work? And I think a beautiful example of that happened during COVID, is the way we did clinical trials. Now, let me give you a couple of examples of that. Historically, there were certain attributes of clinical trials which were very time-consuming, like the recruitment process, the consent process, the tedious event adjudication that used to happen, the limited generalizability, and this led to exorbitant costs, and they have limited capacity to improve rapid answers to important clinical questions. But today, in a matter of few months, the COVID-19 pandemic has incited major changes to the infrastructure of clinical trials that have transformed and improved the potential to generate high quality evidence. And let me give an example. Recruitment. Amidst the COVID-19 pandemic, both social media and digital health platforms were leveraged in novel ways. And what we were able to do because of that is we were able to get a heterogeneous cohort of participants. The Solidarity trial, right? We all know about the Solidarity trial. A randomized clinical trial of hydroxychloroquine as post-exposure prophylaxis in COVID-19. They used social media to outreach, and they recruited more than 800 patients, 50% of whom were women, in less than 2 months. This is huge. Can you imagine recruiting that many number of patients in less than 2 months, and they used social media? Now, after they identified and recruited the patients for the trials, there were difficulties, which usually consent process is a very time-taking process. It's this 50 pages people have to sign. The person has to sit there. They come to your OPD one day. Your person sits there, explains to them everything. But using technology, using telephone, using Zoom, using all these different all these platforms, they were able to get remote consent, and they emailed it to them, and they got an approval. And this was just phenomenal. So adversity helps you drive innovation, and that's what COVID did. Some of the very nice examples that Dr. Chakraborty and Dr. Das have talked about are about AI and predictive analytics. And I would just like to add on that. If you go back and see how medical science has evolved, Dr. Gupta, the way medical science has evolved is previously, 60 years ago, there was no treatment, right? There were hardly any treatments compared to what they were today. So what they would do is you would study the natural progression of disease. So, somebody has a heart attack, you would sit on the bedside and you would note, okay, the person's blood pressure is going up, blood pressure is going down. You would note it down, and you would try and find the natural progression of disease. And then you would say, you know what, because this problem happens, let me try this medicine, fit it here, and see if this works. So that is how treatments were found, pathophysiology was found maybe 40, 50 years ago, right? Then what happened? Then we started saying, okay, now the treatments are evolving, new medicines are coming up. This is all technology, right? The use of aspirin, the use of streptokinase, this is all technology. Newer treatments, newer understanding of diseases is happening. Pharmacogenomics is playing a very important role. Right now we are saying, you know what, if somebody has a fever, everybody gets a Dolo or paracetamol, right? Now, or if you have blood pressure, then I will give you amlodipine. So here, you take amlodipine. This is the first line. With pharmacogenomics, we are going to come out and say, you know what, based on your genetic profile, you may better respond to a beta blocker or an ACE inhibitor compared to amlodipine. So, pharmacogenomics and pharmacogenetics are going to play a very important role going forward, I feel. So this is the way, and then, so we were talking about how diseases were evolved. That is why when you go back and see the natural history of diseases is something which is volumes and volumes of books available. So then came the thought, what can we try and prevent the risk factors? Can we try and identify the risk factors for diseases before? So we came the concept of preventive screening. That means that, if you are a 50-year-old person, you should have an ECG every year or every other year or something of that sort, something along those lines. Everybody should get their cholesterol checked after a certain age. So then came the effect of preventive screening. But now the question comes up, can we try and predict an event? Can we try and predict who are those people who will actually benefit from cholesterol screening? Who are those people who will actually benefit from blood pressure screening? And that is where predictive analytics are going to come into the picture. And that is actually what's happening in other parts of the field, right? If you see your car, previously they would say, for every 5,000 kilometers, go get your brake pad changed, go get your brake oil changed. So that was prevention. Now they're going into predictive. You know what? When it reaches a certain level and you get X, Y, Z things, that is when you have to get it changed. So that is predictive analytics. And now this is slowly and steadily, with a vast amount of data that is being collected on all different formats, this is going to be the future of healthcare. Whether it is wearable devices, whether it is the the data from the EMR, the electronic medical records, which are now booming, virtual healthcare, everybody's entering it into a computer. My X amount of patient has this HbA1c, and I'm giving him this medicine. And, 3 years later, he develops retinopathy or nephropathy or one other complication. The question is, they will go back and study this data and see, was there something else with which we can try and predict who's the problem, who's going to develop the problem, who's not going to develop the problem. So I think the world of the innovation that's going to happen in India and across the world, in the world of medicine and cardiology per se, because I'm a cardiologist, is going to be phenomenal. And this innovation is going to happen not just in the treatments, but also in trying to understand the disease pathology. I think COVID-19 is a perfect example. I mean, in 9 months, in 10 months of the virus being found, we had a vaccination. I mean, this used to take 20, 30 years, 15 years, 10 years. This is just phenomenal the way technology has and innovation has done that. So, I'm reading this book by Dr. Sachin Gupta, and he's talking about World War C, but he's trying to dissect the COVID pandemic and how it raged. And, everybody in the medical community, including, I'm sure all my esteemed panelists over here will agree that, COVID has taught us that the second pandemic is now another pandemic is around the corner. When it happens, where it will happen in 2 years, 1 year, 6 years, 6 months, 20 years, nobody knows. But it is going to happen. It is a matter of time. So, when that pandemic is to happen, we will, this time if we made the vaccine in 9 months, I'm certain the time frame of that is going to be much shorter, and the acceptability of that will be much shorter. So I think innovation and technology has always been there. It is just accelerated. Predictive and trying to predict diseases, who has complications, is definitely going to be something which is going to be the backbone, I personally feel. It's like that movie Minority X. You try and Minority Report, where you try and stop the crime 1 second before it is actually supposed to happen. So I think that is where I see a lot of this going. The technology, the treatment and medications will continue to evolve like they've done over the last 40, 50, 60, 100 years. Thank you.
Right.
Thank you, Dr. Gupta, and back to you.
Excellent inputs, Dr. Sameer. So, especially, you talked about COVID-19 acting as a catalyst for innovation. And so it actually acted as a catalyst. And so everybody kind of put in their best effort. And I remember the draft telemedicine policy was there. I mean, it existed for last many years, but was, sanctioned in a week's time, when the government saw this happening, and similar steps were taken both by private as well as, government healthcare stakeholders. So that is one. And interestingly, you also broached one topic of predictive healthcare and pharmacogenomics, and, that is how the future looks like, predictive healthcare. That's interesting. So my next question actually will be, to all the panelists, and we'll start with Dr. Das, regarding future technologies, predictive healthcare, and recent developments like stem cell treatment. I was reading one of the days, stem cell treatment is going to revolutionize cardiac care. There are new advancements in CRT devices. So if you can share some of those with the audience, that'd be great, Dr. Das.
Thank you. This is a very, very nice question indeed. And this has been our dream for not only cardiologists, but also most of the healthcare providers, especially the doctors, who wanted the chronic disease to be eliminated. So stem cell concept was a very much known phenomenon, not for last few years or so, is for long many years. But somehow or other, the application of stem cell therapy has not been successful in most of the trials. Isolatedly, there has been positive trials in some locations, as for example in Kazakhstan, people, they have shown that stem cell therapy really works. In some other area in Russia, as well as in Europe, the stem cell therapy could not be shown as a positive kind of therapeutics for chronic diseases, especially the cardiac diseases. For cardiac diseases, there are mainly mainly two or three conditions which are of very close to most of us. Is one is acute myocardial infarction, and second is the dilated cardiomyopathy, and third is of course some of the arrhythmias. Now, first one I'll talk about is the acute myocardial infarction, where actually there is clotting of the blood inside the coronary artery, which ultimately gives results in the form of necrosis of the tissue. But before necrosis, actually, there can be ischemia, then some damage to the cells without completely making the patient, making the cell to die. But those dead cells, which we also call as the necrosis, they cannot recover. Now, if some mechanism could have been there so that even after the infarction, the necrotic cells that have occurred there, we could revive the normal cells to or multiply the normal cells in that area. Now, stem cells theoretically fantastic that if they are given inside the coronary arteries, and if the environment is made appropriate, then they will grow, and ultimately either they will make a new angiogenesis, or they will make new mesangial cells genesis, or they will make even the myocardial cells, that is myocyte cells also possible. But that really did not occur. It has occurred to a limited extent. It has, say, for example, been successful. If I can recollect it properly, around 10 to 15% of cases there has been the success rate. With that success rate, actually, industry could not be motivated to promote it, not to invest more energy and money in the stem cell therapy for myocardial infarction. Having said that, the attempt is still going on, especially in the acute myocardial infarction, as well as the dilated cardiomyopathy, where the cells get damaged literally, and that's why the function gets less. And if the normal cells can be put into the cardiac system, definitely there will be improvement in the ejection fraction or cardiac function. Now, this is one side of the story regarding the stem cell therapy. The other side of the story is that there could be some stem cells made which could actually take up certain kind of drugs, or certain kind of vaccines even, or certain kinds of viruses or bacterial products. Now, they could be put inside the arteries, and they could be put in the particular area where the actions can take up, and ultimately they can do some mechanical changes in that particular area where the disease is there. So this kind of experimentations are still going on. And third thing, I would like to tell that stem cell, the therapy is still on the experimental side. It has not yet come into the real picture. It has not come yet into our recommendation part. But once some of the barriers like immunological phenomenon and also the rejection phenomenon are over, then possibly the sustenance of the stem cell therapy will be possible, as it happened in the bone marrow transplantation. But I think then and then only we'll be able to apply that in cardiac therapeutics. Over to Sachin.
Thank you, Dr. Das, for your inputs on stem cell therapy. Now I'll move over to Professor Rabin Chakraborty. So, Professor Rabin Chakraborty, you are also electrophysiologist. So we'll like to know what are the opportunities for physician entrepreneurs in field of cardiology or newer innovations like stem cell and pharmacogenomics. which are the other areas related to electrophysiology or other branches of cardio? I think you are on mute, Professor Chakraborty.
Thank you,
Yeah.
Sachin. Again, as you said that the electrophysiology cardiac arrhythmia is a huge area, and now because when we became cardiologists long time ago, then hardly there was anything. We did not have EP machine. It was a Mingo apparatus through which used to do the ECG, sort of, papers after papers. I still remember at PGI Chandigarh we used to do like this, and there was no such machine available. From there, the EP machine has started, and so many developments. Nowadays, we are doing 3D mapping, and then 3D mapping has also been advanced further. Now, actually, people are also using remote controlled devices to do electrophysiology study, which is again a further advancement. Now, coming to a lot of innovations in the sense, the first and foremost important area in cardiac electrophysiology is the diagnosis, especially certain areas, for example, syncope. This is one area where patient is vague, doctor is equally vague. No one knows what exactly is happening. So there are a lot of ways to make a diagnosis. People are a good diagnostic, good story, good history. That is probably the most important. That's what the examiner, they all ask the question. They expect the candidates to answer. But at the same time, a lot of devices, for example, 24 voltage is progressively has been found to be useless. Just one 24 voltage may not have profound effect. So people have gone for long term, 3 days, 7 days, months, 3 months. This is also there for quite some time. Nowadays, we are actually, people also use the implantable devices. Nowadays, we are getting a satellite device, satellite driven data processing by which this is being processed. At any time, patient gets palpitation, capture it, and you come back to your doctor. And you need not come to your doctor, you can actually send the message to the doctor. Doctor actually can capture those satellite driven images in his or her mobile phone and see what exactly is going on in the patient. This is another thing. So, a huge area in diagnosis of cardiac arrhythmia disorder both tachyarrhythmia, bradyarrhythmia, syncope. A lot of people they get syncope. People think, well, this could be bradycardia, but eventually it turns out to be tachyarrhythmia, like atrial fibrillation. We know that atrial fibrillation is very quick, short burst of atrial fibrillation may actually drop the blood pressure and patient will feel giddy, and there are a history of episodes of short transient loss of consciousness, ventricular tachycardia. So these are the huge diagnostic area that can be definitely explored, especially with various technologies, wearable technologies, and other kind of thing. And I'm sure that this is the area which is probably one of the key areas in cardiology at the moment, especially in India, where a patient getting such symptom in a rural area where they may not have any access to to a tertiary care hospital in the city or in a kind of nearby big cities, very helpful. Forget about India. Even in the United States, the people who live in their rural and semi-urban areas, in those areas, these kind of arrhythmia and capture of arrhythmia details can be done by a lot of this kind of wearable devices and so much technology. So this is a extremely key innovative area in my mind where cardiac arrhythmia can be taken care of. Similarly, another area what probably we should think of is heart failure. Like in heart failure patient, normally when we see the patient, they are in advanced stage of heart failure. But there are situations we know that the heart failure staging has changed. The heart failure new concept of clinical staging, clinical understanding has changed. Therefore, it is important to capture them well in advance before they actually get severe heart failure. And that is the time if we intervene, you can prolong the quality of life. You can actually prevent hospitalization and re-hospitalization, which is an important marker of survival, important marker of mortality. And for that, it is important to identify them at an early stage. So we know that heart failure today is being classified as heart failure with reduced ejection fraction, heart failure with mildly reduced ejection fraction or medium ejection fraction, nowadays called mildly reduced, and heart failure with preserved ejection fraction. So these kind of devices at a very early stage can identify these patients, which I think Dr. Samir Gupta has mentioned nicely, that there is a concept of healthcare has changed from preventive medicine to predictive medicine. So by which you can predict that this particular patient may actually get into hospitalization or maybe re-hospitalized unless the action is being taken right at this stage. So such prediction is extremely important. Prediction can only be done by such innovative technology. So this is another area I would say in heart failure, in sudden cardiac death, in sort of broad-based syncope. Could it be neurological? Could it be cardiological? And could it be sort of a non-neurological, non-cardiological syncope called pseudosyncope? So this is another thing. Pseudosyncope, huge patient, they come, they may not have anything. They still, they keep on going into cardiology, then neurology, then in laboratory tests after tests, reaching nowhere. So these are the things which are extremely helpful, and of course palpitation and tachycardia. And then comes the treatment part, which already we discussed. So this is one area which has to be considered. Coming to stem cell treatment has been found to be extremely helpful. Before we come to cardiology, I must also share my own kind of experience in the sense that recently I just returned from United States, and there are two very close friend of mine. They're actually working on stem cell therapy in post-COVID, not cardiac. We know that a lot of patients of COVID patient after COVID, they get very sort of lethargy, weakness, muscle cramp. Sometimes they like ongoing muscle kind of weakness, and they call it immunological immediate. Nobody knows what exactly is the mechanism. But they found that some of these patients have been enrolled, they volunteered for a kind of stem cell therapy which has been approved. They are not by FDA, but on trial basis. They are actually thinking India to participate in this trial. They actually approached AIMS, and Dr. Randeep Guleria probably also will be contacted. They might have contacted, because Randeep is a very close friend of mine, because we studied together in PGI. So he is very keen. Similar, ICMR has shown their interest in to take up such project of stem cell, trial in Indian population, especially in post-COVID individual. A small group of those populations may have post-COVID is something like myocarditis or cardiomyopathy, or maybe some kind of shortness of breath, could be cardiopulmonary combination. It is not yet completely defined, as Dr. Das said, that it is not yet completely standardized, but innovations are going on. This is another key area where I think the Indian community should get engaged, and I'm sure from this meeting, this area also need to be focused. And coming back to cardiac arrhythmia and electrophysiology, stem cell has been there, especially in channelopathy. Channelopathy is a one disease where stem cell application is going on, especially in long QT syndrome, especially in other types of the sodium channel abnormalities. So many other channelopathies are there where it is extremely useful. Sometimes in polymorphic ventricular tachycardia, idiopathic VT, they also thought of using the channelopathy. The cardiac arrhythmia, especially in children, to prevent sudden cardiac death, is extremely helpful in some heart disease with sudden cardiac death, particularly hypertrophic cardiomyopathy, where the stem cell therapy could be of some help. So these are the areas where people are quite sort of seriously involved, and these are the areas where a lot of innovations are coming up in sudden cardiac death, in structural heart disease or channelopathy, or even idiopathic so-called still unknown causes of sudden cardiac death. Then you got palpitation, you got syncopal attack, you got non-cardiac condition, as I discussed, something like post-COVID, myositis, myocarditis, muscle pain, some of the neuromyocardial symptoms, or even the neurological symptoms, because a lot of these patients, they get psychosis, or where they found that stem cell may be of some help. So these are the lot of areas which we never knew before COVID. So COVID actually helped us to recognize these things, because we have seen patients. They also helped us to find out how therapy, and also find out to find some kind of way out with a rapid processing of the bureaucratic and technocratic process. Because in any kind of approval, you need a technocrat's input and bureaucrat's input. Bureaucrats' input is extremely prolonged, just not in India, I think all over the world. It is really, really prolonged. But now bureaucrats are also sort of, it is a wake-up call for them that they should also sort of, work fast. They should not keep, the bureaucrats, they always believe in file. They not never open the file. They always close the file and keep the file pending. So now they know, yes, everything should not be filed, only file has to be opened up, and the whole human community, human health has to be taken care of. And one such example, which actually Dr. Sachin Gupta has touched upon, one such extreme example of expedition of this bureaucratic and technocratic process together is the vaccination. Give an example, if you look at Spanish flu, it took years together to settle. And in COVID, you know the vaccine, we got 1, 2, 3, 4, double dose. Now people are actually thinking of the booster dose. United States started, Pfizer, Moderna got approved just last, today is Thursday, Monday it has been approved, Moderna, and India is also considering of using, especially for healthcare workers and people above 65 years. So this is an example where people are actually working really seriously and taking sort of the healthcare in a very serious manner. And first time for a change, even the Union health budget has shown a little high from the for the healthcare point of view. This is a good sign. So I think this is a time when all the entrepreneurs should come forward, when the stakeholders should come forward and try to think how such innovative ideas can be made as a reality. And we as clinicians, as doctors, and perhaps to some extent technocrats, will definitely be there to support and guide them to ensure that at the end of the day, the human life and human health can be taken care of appropriately with a newer and newer technology. Because at the end of the day, we have seen that human life is getting prolonged. The quality of life is getting prolonged. Even a 94, 95-year-old man is getting the best possible treatment sitting in India from the United States with this kind of technology. So with that, I think I'll ask Sachin to take it further. Maybe Dr. Gupta can put his input. Thank you.
Thanks, Professor Chakraborty. So you actually brought in a very interesting point whereby you actually said that some of the stem cell innovation happening in US and clinical trials happening in India. So clinical trials happening in India is a huge opportunity for Indian healthcare ecosystems and entrepreneurs in healthcare. So that's very interesting. But when I move over to Dr. Sameer, my question to Dr. Sameer will be, you've seen a lot of, innovation happening in US and Singapore and Taiwan and Japan. So will you like to share some examples of, some indigenous innovation that might have happened in India, Dr. Sameer, that you know about in field of cardiology?
Yeah. Thank you, Dr. Gupta. I think this is innovations are definitely something which is very exciting. When you sit and so I have kind of I talk to a lot of startups, a lot of approaching for help, mentorship, outlook. So it's very exciting when you meet these entrepreneurs and when you understand what the product is. And I'll tell you some of the shortcomings which I have found actually, Dr. Sachin, because I think they're really relevant for your physician VC platform also. One thing is that healthcare providers are not always a part of the core team of the companies, and I think that is a big lacune for them. What happens is, and I'll tell you, people come to me and they say, what, I've made this product, and like Dr. Chakraborty alluded to earlier, the use of 12-lead ECG is not very common. We do get a lot of work done by 1 lead, 2 lead, and 3 leads. But 12 lead still remains the gold standard. If you diagnose a heart attack, you need a 12 lead EKG to try and accurately define that. So patients come to, these people are coming and they're pitching, I've made this device. It gives you 2 leads or 3 leads, and you can successfully rule out a heart attack with this. Now, this is something which gives you a false sense of assurance. And these people are going out and pitching this to other people. Now, the problem is that they don't have a doctor or they don't have a doctor mentor in their company. And this is a big lacune which is being faced by these companies. And this is kind of inhibits their success. Now, when you go back to the US and you see in other companies, some of the most successful startups in healthcare delivery have come from doctor backgrounds, whether it is teleradiology, whether there is a device, it's called the penumbra device. the Penumbra device is used in as a suction catheter for strokes. And the founder of the company is intervention radiologist, Dr. Bose, I think his name is. So this is a doctor coming out with a device. So he knew the intricacies of what the problem is, and he kind of innovated and made this device. This device is now a multi-billion-dollar company. It is more than that. It is saving countless lives across the world. Countless lives. It is saving lives. So a doctor, I feel, should be there in the core team. Whether these people need to give him equity, they need to give him a salary, or they want to do that you can debate what the right model is. The second problem is, I would tell all the innovators and out there to go and really go for quality. What ends up happening is, once again, they come up with a device, and then the device has a 50% predictive model compared to, it has a 50% success or 70% success as compared to the standard, gold standard device against which it is going to be compared. And this is also a vacuum, because when you go out and you want to now out in the field, whether it's an ECG device, whether that's blood pressure device, oxygen device, whatever you want to call it. This is a very simple example, because they are the ones which are now causing a lot of furor. Everybody's talking about these devices. The quality of these devices needs a lot to it. Some of the companies I've talked to, it leaves a lot to be desired, because if this device is saying A and the gold standard machine is saying B, that is not acceptable, because then either you're overdiagnosing or you're underdiagnosing. So that is not acceptable. So hone on quality, make a very good quality product, because at the end of the day, quality is what is going to sell, nothing else. Nobody in the healthcare community is going to take an inferior quality product and pitch it for you. They will not use it for themselves, and they will not use it for the family members. These are some of the very important lacunae which are currently there in the healthcare ecosystem in India. And the third thing, of course, is cost. For any technology, for any device, for any treatment, for it to be successful, you have to go to scale. And for scale, it has to be cost effective. Whether it's India, whether it's abroad, whether it's Europe, anywhere in the world, it has to be a cost effective solution. Have a doctor or a physician or in your core committee, in your core group, and better if that doctor is there from that specialty. The input that Dr. Chakraborty will give or Dr. Das will give, or I will give in a cardiology device is going to be very different than what a dermatologist, for example, will give in that cardiology device. So have a core specialty doctor in your group. Go on good quality. If you have a core specialty doctor in your group, the quality, he's going to make sure it is going to have good quality. Otherwise, there's going to be a big medico-legal problem for him. So he will ensure this device does not come out if the quality metrics are not met. And the third is make it affordable. And I think these are the three very important things, apart from everything else that Dr. Chakraborty and Dr. Das have very nicely alluded to, which are required in a good startup for it to be successful.
Spot on, Dr. Sameer, spot on. So, you have actually hit the nail. So, so one of the reasons why Physician VC and Whitehall have been conceptualized, we actually noted that in emerging economies like India, so there is a lacuna whereby, innovation is done by, non-medicos, even in healthcare sector. And some of the people, developing these medical devices.
For a second, Samir, I think, as Dr. Samir Gupta said very nicely, this is a very valid point. I think he has been polite, but let me be very straightforward. India, that attitude of copy paste has to go. Like right. You got something somewhere else in US, you just bring it here and start doing copy pasting. Copy paste right. Will not help, because that is the reason why in cardiovascular innovation, cardiologist is not there, and many of them, they're no doctor actually. And you talked about pharmacogenetics and pharmacogenomics. They are also in pharmacology, where Indian pharmacology today is the world leader today. But even then, there's hardly anything. And then the Indian government, this pharmacological strength, they cannot even break that Qatar WTO deal. Even whatever is being patent right by United States, still we have to follow that. When we are the world leader in pharmacology. So government also has to take initiative. And your company, even the startup, should also, and include the chamber, of Commerce. I have spoken to our Calcutta group because I'm the chairman. I'm sure Dr. Gupta also will be able to do it in his area. Dr. Das also as a CSI president we are talking about, but we have our own limitations. We have to accept it. So they should come in the forefront and we should talk more and more. And each area which is so specialized and so important, so relevant for our patient community, the concerned specialist should be a part of the core team. Otherwise, it will not move. Otherwise, why from the innovation will come? That would be my comment.
Yeah, I concur your views, Dr. Chakraborty. So yeah, so that's where role of a platform like Whitehall Hub and Physician VC is there. So you're already part of our mentorship panel, and one of the problems which we saw when some of the innovators who are biomedical engineers or not even engineers but are entrepreneurs otherwise, so they come out with a product and they don't have a clue. So what we did, although we are based out of our company is based out of Singapore, first thing we did was a institutional tie-up. We tied up with Apollo Hospital. So Apollo Hospital is our industry partner, and then any of new biomedical device or innovation uh, coming out of a country like India will actually patch them with Apollo Hospital, and doctors over there can validate that. Having said that, we actually formed a mentorship board with people like Professor Chakraborty, and then we have specialists in all clinical specialties, and this board is expanding every day. So these startups actually work hand in hand with clinical specialists who kind of validate their idea and product, and then they also get a chance to actually uh, do product validation on the patients. So that is where that is how we have structured Physician VC. Also, we want to promote stakeholdership of physicians uh, by providing them with some sweat equity in return of their services. Or if you find some healthcare startup interesting, you can actually invest some money, which Dr. Sameer was talking about, that he has been angel investment. He has been doing some angel investments. So all those things we are trying to do. But Dr. Sameer, you also brought in interesting point of physician entrepreneurs. So you talked about a company, incorporated in USA by a physician, which has become a multi-billion-dollar company. So in India, traditionally doctors have been focusing on hospital as a business, or for entrepreneurship they'll put up a IVF center or a heart hospital, or some other sort of nursing home or a hospital. uh, Recently we have seen trend of doctors becoming entrepreneurs also. But I think doctors also need to become innovators in terms of developing new biomedical devices, because they understand the real problem, they understand the technical issues behind this. So we are already reaching the end of it's 1 hour already, but this is my last question to all of you, and we'll go one by one, starting from Dr. Das. So Dr. Das, uh, what can be done to promote innovation by doctors, so that they become doctorpreneurs or physician entrepreneurs? What kind of incentives can come from bodies like Cardiological Society of India or IMA, or Indian College of Cardiology, and how these forums can work with forums like Physician VC? Dr. Das.
Yeah, yeah. There are two components. One is the individual component. Second is the organizational component. I'll first talk about the individual one. Whenever some innovations are asked for, or they are being in demand, then next question that automatically comes is the incentive. Now, if the incentive is not there, which is in most of the cases, why I'm telling so, because I know at least some of the innovations that have happened during the corona time, but nobody took notice of it, nobody could spread it. I mean, there was no incentive for any innovation. So this is one aspect, and if there is this kind of disincentivization, automatically innovation will not take part. The same thing is happening in USA because there are lot of openings when some innovations are made. It's not only the venture capital concept or the startup concept, or all these concepts are there in USA for a long time. Even in even in European countries also, the incentive part is there, and that is why they are more motivated. In India, particularly, there is no such incentivization for innovative thinking, and there is no sort of training also, no sort of training right from the school or even at the college level, even in medical college. There is no one to talk about innovation. There is no one, and that's why we are not having any kind of innovative ideas, and we are just copy pasters, as pointed out by Dr. Rabin Chakraborty. The second part is CSI or ICC or any other organization. You see, these organizations are made of some people, and these people are coming from the same group, same cohort, where there is no kind of motivation for the innovations. As an organization, what we could do, that we could produce some incentive in the form of awards, in the form of say giving monetary benefit, or in the form of giving training benefits for 3 months to 1 year. So these are some of the motivating points we could make from our organization, so that the research work and some innovation points go on go on, and they can be inculcated, and they can be of use for everyone. Now, organizations, they have got again certain limitations. They don't have the power of the implementation is very, very important. If someone is finding out something new, if that is implemented, and if that is effectively carried out, and if the results are obtained in the appropriate way, then only the implementation will happen, or implementation techniques will be followed up, and ultimately they can give leeway to the further innovations of those points that have been implemented. Now, either the bureaucratic process or governmental machinery, whatever you call it, actually there is no connection between the government or bureaucracy with the technology, or with the say organizations. And I am actually passing this message to every forum, that whenever I get the chance, I tell this particular point. There is a total disconnect between the technocrats, that is the doctors, with the industries or with the government, and that is why the advocacy part cannot be taken up by the organizations. And if there is no advocacy, if we don't have the fear of not implementing the protocols, or not implementing the guidelines, what we call as the guideline mediated therapy, if they are not followed up, and we cannot put our pressure, then automatically the lack of implementation, or lack of willpower will be there, and the things that are happening now will be carrying on. So that's a very harsh word I have used, but this disconnect will have to remove in different ways. Those will have to be carried out, and especially from the government side, they'll have to come much more with open hands, and they'll have to be free, and then only the connection will happen, and ultimately the benefit will be there for all the people. Over to Sachin.
Right. Thank you, Dr. Das. So I understand that both government and private players need to join hands. But I remember one of the interesting things, when you are president of Cardiological Society of India, you actually instituted a award for innovation in cardiology, so that any cardiologist who comes up with the new innovation is given some monetary benefit. I think societies like CSI and Indian College of Cardio and IMA, need to have such incentives in place. So again, 1 lakh may not be a large amount of money, but the kind of recognition you get among your peers is a very motivating factor. So I think on our part, as professional bodies, we need to play our part, and then of course parallelly we need to work closely with government to improve the overall scenario. Now I'll move to Dr. Rabin Chakraborty to understand his thoughts about how professional bodies like CSI and in College of Cardio and Chamber of Commerce can play in promoting innovation and potentially with forums like Physician VC.
No, I think Dr. Das is basically very straightforward and very, very clearly he communicated the message. I entirely agree with what he said, and I have seen him being very sort of proactive about this kind of um, statement on repeated occasions. In a simple word, as probably he said, that unless you take medical professional, especially the qualified top-ranking medical professional as a partner by government administration and bureaucrats, unless this partnership come, it will be difficult. It will go. For example, a Cardiological Society of India, just because of Dr. Das, very keen, very proactive. Last CSI meeting when he organized it, he gave an innovative kind of a prize or something. But it stops there. To take it beyond that, this partnership has to be continued. And at the same time, in addition to medical professional, I also strongly suggest, I myself tried with our Chamber of Commerce to incorporate IIT, especially Kharagpur IIT and Bengal Engineering. And we had some kind of meeting, but again, it did not move further because the moment it went beyond their level, technocrats level to bureaucrats at IIT level, they just saw the file and did not move it forward. So there is some kind of, I would say, lethargy, some kind of tardiness of these bureaucrats and
I think there is some connection issue at Professor Chakraborty's end, but point taken that uh, government needs to be proactive, and recently we have seen some proactive steps being taken from the government and in promoting innovation. They actually set up a ICMR Center for Innovation and Biodesign at campus of PG.
Dr. Sachin, Dr. Sachin, you are not audible.
You're not audible, Dr. Sachin. Das, I think you've raised some very important points. I think Dr. Sachin is back. No, he's still not
Dr.
audible.
Sachin, you are not audible. Might be your headphone is not working.
So I think, Dr. Das, we're already over time, and Dr. Sachin's thing is not working. So I'll just take the onus of thanking everyone who's here. Thank you everyone for joining, and I think this was a very useful discussion, and I also learned a lot today. And Dr. We had very esteemed panelists, including Dr. Das, the former president of CSI, and Dr. Rabin Chakraborty. He's the president of the ICC, Indian College of Cardiology, and then I was there, and Dr. Sachin is having some technical issues. But thank you everyone for joining, and I think the team over here will update you on the next webinar and the next education session. And if you want to reach out to us, you can connect with us on LinkedIn or on Twitter. You can find us on both. So thank you so much. Bye-bye.
Thank you. Bye-bye.
Thank you. Bye-bye.